Dear students, today my class is antiviral drugs, and I will enumerate the antiviral drugs non-retroviral. Non-retroviral. You should go through the page number 849, new edition of the, I would say, this KD Tripathi. There is a clear classification of antiviral drugs. We have a anti-herpes virus drugs, anti-influenza virus drugs, and then we have a anti-hepatitis drugs. But we can describe these anti-hepatitis drugs into two headings, for hepatitis B and for hepatitis C. So you should take one drug amongst the all so that you can describe, I mean say, it is pharmacology, it is pharmacokinetics, it is pharmacodynamics. In the antiherpes virus, we have idoxuridine, trifluridine, acyclovir, valacyclovir, famciclovir, ganciclovir, valganciclovir, cidofovir, and foscarnet. And there are so many, almost 20 drugs. But it is very difficult to have this session for the whole drugs. But I will tell you the basics of antiviral drugs, and then you have to describe yourself. It is pharmacokinetics, it is pharmacodynamics separately. And then in the next lecture, which will be on the coming Thursday, that will be of anti and that will be a separate issue, antiviral drugs, but antiretrovirus. So antiviral drugs basics I am enumerating over here. So this is the whole scenario of viral infection. There is so much of viral infection. It is spread over so many diseases are there. Viral infection is of encephalitis. We have meningitis, encephalitis, meningitis. We have JC virus, measles, LCM virus, arbovirus, rabies, pharyngitis. We have adenovirus, Epstein-Barr virus, that we call as EBV, and cytomegalovirus. Cardiovascular, we have Coxsackie virus. Hepatitis, we have A, B, C, D, E. Skin infection, we have Varicella zoster virus. So this is all given here. You should know as doctors that there is a myriad of infection regarding the viral infections. So we have parvovirus and rubella virus, measles. So these are all, once you go in the microbiology, and herpes zoster virus, herpes simplex virus, and when we have pneumonia, influenza virus, type A, type B, like nowadays we have, COVID-19, and they have given us a new term. So you should know about the pathophysiology of the COVID virus, that is in the, in microbiology. But so far as therapeutic is concerned, it is yet to be noted down what is this, what is pharmacology, what is midosavir is the, antiviral, that you should know why it is, how much it should be taken in the clinical practice. Now today I am talking about the basics. So understanding virus, they are different from other microbes. Viral replication is there. Once it is inside the body, it does not exist of its own outside the body. So inside the body, it has it has to exist inside the body. A virus cannot replicate on its own. It is not an independent that it can with the human or with anybody. It can be developed. It must attach to and enter a host. Host is very important. It then uses the host cell's energy to synthesize protein, DNA, and RNA. So once it is inside, then only it can synthesize protein, DNA, and RNA. Now understanding virus, we have, viruses are difficult to kill because they live inside the cell. Any drug that kills a virus may also kill cells. So specificity is very important. Once we use the drug for the viruses, it should kill the virus, not the human being. It should affect on the virus, not on the human being. So there is the specificity as you have gone through the antifungal, antibiotic, and this virus also, we should have a specificity of the drug. Then we have antivirals available for many viral infections. Viruses controlled by current antiviral therapy. We have cytomegalovirus, CMV, hepatitis viruses, herpes viruses, human immunodeficiency viruses, HIV, influenza viruses, that is flu. We have H1N1 and respiratory syncytial virus, so RSV. So there are the different antivirals we have to deal with. Now, antiviral drugs. Viruses have no cell wall and made up of the nucleic acid components. They are made up of nucleic acid components. Virus containing envelope antigenic in nature. So the envelope which has outer covering, they are antigenic. So they have got high molecular weight and they adhere to the surface of the host. So they are antigenic in nature. Viruses are obligate intracellular parasites. So we can say that viruses are intracellular parasites. And also they do not have metabolic machinery of their own. So they use the host enzymes. Now, antiviral drugs, certain viruses multiply in the cytoplasm, but others do in the nucleus. So they are cytoplasmic viruses here. So we have they act on the cytoplasm and they act in the nucleus also. Most multiplication take place before diagnosis is made. So we have to. So it is very, difficult, cumbersome to diagnose a person which type of virus it has, and before that the diagnosis is not done. So we have to think that virus gives the havoc experience, gives the bad experience to the host. Now, antiviral drugs, we have many antiviral drugs are purine or pyrimidine analogs. So there are two types of purines and of pyrimidine analogs. Many antiviral drugs are prodrugs, many. So inside the body they become the, because they have got a low, bioavailability. They must be phosphorylated by viral or cellular enzymes in order to become active. So once they enter the body, they are phosphorylated there, and they need the enzyme, viral or cellular enzymes in order to become the active. So antiviral agents inhibits active replication. So active replication is there, is being inhibited. So the viral growth resumes after drug removal. So replication is very important in order to maintain its progeny inside the body. So antiviral, how they act? Key characteristics of the antiviral drugs are able to enter the cell infected with virus. So when they enter, they are infected with the virus. Then we have, interfere with viral nucleic acid synthesis and or regulation. So they interfere with the viral nucleic acid synthesis and or regulation. Some drugs interfere with the ability of a virus to bind to cells. So they bind to the cells, and some drugs interfere with the ability of virus to bind to the cells. Some drugs stimulate the body's immune system. So some drugs they stimulate. So best response to antiviral drugs are patients with competent immune system. So a healthy immune system works synergistically with the drug to eliminate the viral activity. So immune system is very important. Once a person who is having good immunity and they come out with this infection, but that as the case of the this virus, which is COVID-19, once they enter the human being and they immunocompromised patients, they die. They have got the comorbidities, and this is how they act, and they show havoc in the body. Now, antiviral drugs used to treat infections caused by viruses other than the HIV. So antiretroviral drugs are those used to treat infection caused by the HIV, the virus that caused the AIDS. Herpes simplex virus is there. HSV, there are two types. Oral herpes, we have HSV1, and we have genital herpes, we have HSV2. That is herpes simplex virus. Then we have Varicella zoster virus. There are of two types. One is the chicken pox, another is the shingles. So they are also two. So this is, I have already told you that this kind of virus, they have got the influenza virus anatomy, like outside there is a, I would say, neuroamidase, and there is a agglutination that takes place, and there is a capsid lining, and there is a lipid envelope, and then we have a RNA inside. In the, I would say, cytoplasm, we have RNA. So these are the RNA viruses. So antiviral drugs, they are non-retroviral. Mechanism of action is inhibit viral replication. Used to treat non-HIV viral infections. We have non-HIV viral infections like influenza viruses, HSV, herpes simplex virus, VZV, Varicella zoster virus, CMV, we have cytomegalovirus, hepatitis A, B, C, we have HAV, HBV, and HCV. They are, I would say, non-retroviral. And adverse effects it varies with each drug. Healthy cells are often killed, also resulting in serious toxicities. So it is not specific. There are cells inside the body, they kill them also. So it is not specific, these drugs. So antiviral drugs, current antiviral agents do not eliminate non-replicating or latent virus. So whatever the antiviral drugs are there, they are antiviral. Once they eliminate non-replicating or latent virus, they are not eliminating. So current antiviral agents do not eliminate non-replicating or latent virus. So effective host immune response remains essential for the recovery from the viral infection. So clinical efficacy depends on the achieving inhibitory concentration at the site of the infection within the infected host. So it is the concentration. Once it reaches the target site, it will really eliminate the infection. So it depends upon the concentration, that is the pharmacokinetics, and the effector site is the, I would say, bacteria. So number one is that non-replicating and latent virus is not being killed by the antiviral drugs. So antiviral drugs, we have stages of the viral replication, cells entry, and we have different, how they replicate. And so there should be entry point from the, the virus to the host. So there are cell entry, there's the attachment or penetration. These are the two adjacent, sites. Then it is uncoating. Then there is a transcription of the viral genome. Then is a translation, assembly of the viral components. Then there is a release. Then it releases outside. So this is the. So you can say they are, depicted on 6 points, or with the penetrations 7. So this is the scenario at different places. So while absorption is there, so the blocked by N-furidine, HIV, I have taken the example here, non-specific, once it penetrates, so here it affects at the viral absorption. Then uncoating also, it is blocked by the amantadine, influenza A, so this is the example. Then blocked by the formiviral CMV, it blocks, it acts on the early protein synthesis. Then there is a nucleic acid synthesis. It is blocked by the purine, pyrimidine analogs, reverse transcriptase inhibitors. I am enumerating here also anti-HIV, so you need not to go, puzzled over here. So different penetration, then uncoating, then early protein synthesis, then nucleic acid synthesis. Then we have latent protein synthesis and processing this blocked by the methazone or variola, or this is a protease inhibitors. It is here latent protein synthesis, and that you can come across in the HIV. Then here we have rifampin vaccinia. It is packaged and assembled by over here, packaging and assembly. It is here, and then it is viral release. It is blocked by the neuroamidase inhibitors, that's influenza. So at different points, the different targets. Different targets are there, and different drugs act at different target points. So taking the life cycle of a virus into consideration, you have to consider the different points, entry, from entry to release. From entry means absorption till release. The different drugs act at different spots. So it is not that I mean say the drug will be targeted at one point. No, there are 5, 6, 7 points where the drugs are being targeted. So this target is the receptor where the drug acts. So this is the major target areas. Then antiviral drugs, anti-herpes virus agents, we have acyclovir, valacyclovir, famciclovir, penciclovir, ganciclovir, cidofovir, foscarnet, trifluridine, vidarabine, and idoxuridine. So this is the scenario of different antiviral, anti-herpes agents. Now antiviral drugs with the acyclovir and it is congeners. Valacyclovir is a prodrug of acyclovir. Cyclovir, a prodrug is valacyclovir. Why prodrug? Because the bioavailability is less of, if we say acyclovir. So better bioavailability once we give the valacyclovir. So inside it is, it reaches in the maximum concentration, so bioavailability is increased when we have because the maximum antiviral drugs have got less, bioavailability. So they are the prodrug. Famciclovir is hydrolyzed to penciclovir, so and has greatest bioavailability. And penciclovir is used only topically, whereas famciclovir can be administered orally. So topically, there are so many herpes zoster virus is topically. We have to use this drug topically at that time. So we can have penciclovir, it is topically used, and famciclovir can be given orally. Now, antiviral drugs, we have pharmacology of acyclovir and congeners, acyclovir, valacyclovir, ganciclovir, famciclovir, penciclovir, all are guanosine nucleoside analogs. So these are the nucleoside analogs, these are all antiviral drugs. So pharmacology, acyclovir and its congeners, they are nucleoside analogs. You have to remember this. And then antiviral drugs, we have mechanism of action of acyclovir and congeners. All drugs are phosphorylated by a viral thymidine kinase, TK we call it. And all drugs are phosphorylated by viral thymidine kinase, then metabolized by the host cell kinases. The host cell kinases metabolize it, but viral thymidine kinase, phosphorylates, that you have to remember, to nucleotide analogs. The analog inhibits viral DNA polymerase. So the net result is the viral DNA polymerase is inhibited. So there is viral side, like it kills the virus. So only actively replicating viruses are acted upon by drugs. So it should be dividing and actively replicating drug. Virus is being inhibited. Antiviral drugs, acyclovir is thus selectively activated in cells infected with the herpes virus. So inside, uninfected cells are not phosphorylated. So this is the mechanism of action of acyclovir. So there is a guanosine and this is the acyclovir. It is the acyclovir structurally resembles the nucleoside deoxyguanosine. Then there is it is phosphorylated. Then guanosine nucleotide it is formed. Then DNA polymerase. Then it is being inhibited over here. So it is not. Their reproduction is being inhibited. So this is phosphate. We have acyclovir. It is thymidine kinase, which is from the virus, and then there was a false nucleoside is formed, and acyclovir triphosphate, which is active triphosphate of the acyclovir is more having bioavailability. So DNA polymerase is blocked by false nucleoside assembly of DNA. So acyclovir has no effect on a cell not infected by a virus, that is with normal thymidine kinase, by a virally infected cell. The thymidine kinase is altered and converts the acyclovir, which resembles the nucleoside deoxyguanosine, into a false nucleoside which blocks the DNA synthesis by DNA polymerase. So that you have to remember about the mechanism of action of the acyclovir. This is an example, and you can enumerate these examples in other drugs. Then antiviral drugs, antiviral spectrum, we have acyclovir. It is HSV1, HSV2, so Warsaw zoster virus, shingles. So ganciclovir, cidofovir, and it is cytomegalovirus. Phencyclovir, herpes genitals and the shingles. Foscarnet is HSV, BZV, CMV, and HIV. Penciclovir is herpes labials. So it can use in the at different portions, different I would say as topical. So trifluridine, herpes keratoconjunctivitis. So we can use it as I would say ophthalmic. So this virus is also on the ophthalmic part. So we can use as a, I would say drug on this. So there are different salts where you can use the antivirus. And drugs have got different, I would say, it has a topical, it has a ophthalmic, it has a injectables, it has a, I would say, oral. So different formulations are present. So antiviral drugs pharmacokinetics of cyclovis. Oral bioavailability is 20 to 30%. Distribution in all tissues, including CNS. So penetration is good. It can go to any tissue. Renal excretion is more than 80%. Half-life is 2 to 5 hours. Administration is topical, oral, and IV. So I have told you this acyclovir has got 3 forms. It is topical, it is oral, it is IV. Then adverse effects of acyclovir, ganciclovir: nausea, vomiting, and diarrhea. Nephrotoxicity, crystalluria because they are nephrotoxic. Hematuria, renal insufficiency. Myelosuppression, so there is a neutropenia and there is thrombocytopenia, ganciclovir. So they have got a lot of problems, they have got a lot of adverse drug reactions and side effects. So that's why you have to use, once you give the, I would say, antivirus, there is not orally, so nausea, vomiting is present, prevalent there, and diarrhea also. So nephrotoxicity would say crystalluria, hematuria, renal insufficiency. So in myelosuppression also we have a neutropenia. Neutrophils are less, and thrombocytopenia, I would say platelets are less due to the ganciclovir. So you have to have the profile of the, I would say, adverse drug reaction of each and every drug, and you enumerate it. And these are the general, I would say, once you give the drug orally or IV, these are the, I would say, maximum side effects which are taking place. And the antiviral drugs, your therapeutic use, acyclovir is the drug of choice for HSV genital infections, HSV encephalitis, HSV infections in immunocompromised patients. Ganciclovir is the drug of choice for cytomegalovirus retinitis in immunocompromised patients. Prevention of the cytomegalovirus disease in transplant patients. So that's why once you have a transplantation of any type, like liver transplantation or kidney, renal transplantation, whatever, so there is a probability that there is a we have to give the antivirus because for the prevention of these diseases. Antiviral, we have cidofovir. It is also approved for the treatment of the CMV, retinitis in immunocompromised, I mean, say, patients. It is nucleotide analog of cytosine. No phosphorylation required. So in the cidofovir, there is no phosphorylation. I mean, say diphosphorylation or triphosphorylation. It inhibits viral DNA synthesis. Available for, it is also given IV and intravitreal injection. We get topical. We get, but there is also nephrotoxicity is a major disadvantage of this cidofovir. And pharmacology of the vidarabine. Vidarabine is a nucleoside analog, adenosine. Antiviral spectrum of vidarabine is HSV1, HSV2, and VZV. So its use is limited to HSV, I mean say keratitis only. And we have vidarabine. The drug is converted to its triphosphate analog, which inhibits the viral DNA. So it is being, I will say, phosphorylated, and it becomes the triphosphate, and then inside it inhibits the DNA polymerase. Oral bioavailability only 2%. See, vidarabine has got a 2% only bioavailability. Administration is ophthalmic. It is ointment also. Use it in HSV, keratoconjunctivitis in immunocompromised patients. Side effects is anemia and SIADH, or adverse effects. So anemia and SIADH, antidiuretic hormone is in this. It is due to the, I would say, once we give the vitarabine, these are the two adverse drug reactions which are taking place. So now we have a pharmacology of the trifluridine. Trifluridine analog, it is trifluridine is a pyrimidine nucleoside. So it's a pyrimidine nucleoside analog. It inhibits viral DNA synthesis. Antiviral spectrum trifluridine is HSV1, HSV2, and VZV. It is limited use is topical, ocular, HSV, keratitis. Then we have phoscarnet. Phoscarnet is an inorganic pyrophosphate analog. It's a pyrophosphate phoscarnet. It directly inhibits viral DNA and RNA, polymerase, and viral inverse transcriptase. It does not require phosphorylation for antiviral activity. So there is no triphosphate or monophosphate, diphosphate, triphosphate. It directly goes and it's an inorganic pyrophosphate, and then it affects on the, I would say, it does not require phosphorylation. So it directly inhibits the viral DNA and RNA. So it can be used in the DNA virus or RNA virus. So phoscarnet is used for HSV1, HSV2, VZV, CMV, and HIV. Oral biology is also 10 to 20%. Distribution to all tissues, including CNS, and there is administration we can have through IV also. Now, adverse effects of the phoscarnet is hypocalcemia and hypomagnesemia. So once we give the phoscarnet, there is the calcium less, there is the magnesium less due to chelation of drug with the divalent cation or common. So once we give the drug orally, phoscarnet, it chelates with the calcium, it chelates with the, I would say, magnesium. That's why there is a hypomagnesemia and hypocalcemia. And there is also neurotoxicity and nephrotoxicity, both. Headache is there, there is a hallucination, seizures also. Nephrotoxicity is acute tubular nephrosis, interstitial nephritis also is produced. So therapeutic use of the phoscarnet is an alternative drug for the HSV infection, acyclovir resistant. So those, I mean, patients who are acyclovir, those drugs, acyclovir resistant, we can give this phoscarnet. It is given to immunocompromised patients also. CMV, retinitis, ganciclovir resistant, immunocompromised patients, we can give this. So respiratory viral infection we have also, like we have today H1N1 nowadays, and we have also, I would say, COVID-19. So amantadine and rimantadine, oseltamivir and zanamivir. These are the, I would say, group of, I would say, drugs. They are coming in the neuraminidase inhibitors, and RSV bronchitis we give, and ribavirin. So these are the drugs which are for H1N1 influenza virus. And amantadine and rimantadine, influenza prevention and treatment of influenza A, inhibition of the viral uncoating. It inhibits at viral uncoating stage by inhibiting the viral membrane protein M2. And influenza A virus, amantadine has anti-Parkinsonic effects. So amantadine, I have already given the lecture on anti-Parkinsonism. It is also used as in the Parkinsonism. So it acts as amantadine acts as anti-Parkinsonism. Now antiviral pharmacokinetics of the amantadine. Oral biology is 50 to 90%, so it has a good, bioavailability, and that's why we use it in the Parkinsonism. Amantadine crosses the BBB, blood-brain barrier, whereas rimantadine does not cross. So we can say that amantadine is specific for the, Parkinsonism, because it goes higher centers and it has a 50 to 90% bioavailability. So it crosses the blood-brain barrier. Rimantadine does not cross extensively. Administration is through oral. So neuraminidase inhibitors influenza, oseltamivir and zanamivir. Influenza contains an enzyme neuraminidase which is essential for the replication of the virus. Neuraminidase inhibitors prevent the release of the new virions and their spread from cell to cell. So this is the inhibitor at neuraminidase. It prevents the release of the new virions in their spread from cell to cell. So it does not go from one cell to another cell. It retards its growth. It retards its entry. Neuraminidase inhibitors, we have influenza, and we call it oseltamivir and zanamivir. These are effective against both types of the influenza A and influenza B. Do not interfere with the immune response to influenza A vaccine. So it does not interfere. Can be used for both prophylaxis and acute treatment. So I have already told the drug is given for the diagnostic, prophylactic, and therapeutic. It is for the prophylactic as well as the acute treatment. So this is the, again, it is to be repeated. I have already given this sketch-out diagram. And antiviral neuraminidase inhibitors in oseltamivir, oseltamivir is orally administered. Zanamivir is given intranasal. So intranasal is also a route that you can, I have already told you that in the insulin case in the long back in 2002, 2003, it was tried, it has failed. And the intranasal route is a good route, and zanamivir is given intranasal also. Risk of bronchospasm with zanamivir is there. And then we have a pharmacology of the ribavirin. Ribavirin is the guanosine analog. So inhibition of the DNA polymerase is the mechanism. Antiviral spectrum is DNA and RNA viruses are susceptible both. So including influenza, parainfluenza virus, RSV, and Lassa virus. So these are the ribavirin, and these are given like ribavirin. It is distribution in all body tissues, because I told you a drug is the best. A drug is the best once it enters all tissues, like CNS, where it has to effect. So distribution in all body tissues is this ribavirin. And then we have administration is oral, IV, inhalational, and in RSV. So we can give, we have 3 routes of administrations. Then anemia and jaundice are adverse effects of this ribavirin, and not advised in pregnancy, because it is it is not given during the pregnancy because of the teratogenic effect. And therapeutic use of ribavirin, the ribavirin is the drug of choice for the RSV, bronchitis and pneumonia, bronchiolitis and pneumonia, hospitalized children given by the aerosol, Lassa fever we can also give. Ribavirin is an alternative drug for influenza, parainfluenza, measles virus infection in immunocompromised patients, we can also give it. Then antiviral drugs, we have hepatic viral infection. We use also interferons, and we use lamivudine, cytosine analog. It is of the cytosine analog. So HBV. So this is the hepatitis B virus. Entecavir. This is another, but this is not a cytosine. This is the guanosine analog. So we can use the hepatitis B virus. And then lamivudine resistant strains. We can give these lamivudine and entecavir where there is a resistant strains. We can have ribavirin, hepatitis C with interferons. So we cannot give ribavirin lonely to the hepatitis C. We can give it along with the interferon. So what are interferons? Interferons are natural proteins in the body and produced in the cells of the immune systems in response to the correct changes by foreign agents, such as the viruses, bacteria, and parasites and tumor cells. So we can give interferons also. Antiviral, they are immunomodulatory and anti-proliferative actions they have. We have 3 classes of the interferons: alpha, beta, and gamma. And interferon, alpha and beta interferons are produced by all the cells in the response to viral infection. And gamma interferons are produced only by lymphocytes and NK, natural killer cells, in response to the cytokines. So you have to remember, immune regulating effects Gamma has been antiviral activity compared to alpha and beta. So gamma has a less antiviral activity as compared to alpha and beta interferons. So we have now mechanism of action of the interferons. It induces induction of the following enzymes: a protein kinase which inhibits the protein synthesis. So these are the, I would say, where they act on the three places mainly: protein kinases, oligoadenylate synthase, and phosphodiesterase. So protein kinase which inhibits the protein synthesis, and oligoadenylate synthase which leads to the degradation of the viral mRNA. So they degrade the mRNA of the virus. And a phosphodiesterase which inhibits the transfer RNA. The action of these enzymes leads to an inhibition of the translation. So translation is being inhibited. So they act on the three, I would say, supports. So antiviral drug spectrum interferon alpha includes HBV, HCV, and HPV. Anti-proliferative action may inhibit the growth of certain cancers also, like Kaposi sarcoma and hairy cell leukemia. So it can be given as anti-cancer also, this interferon alpha. So pharmacokinetics interferons oral biology is 1% only, less than administered intralesionally, subcutaneous, and IV also. Distribution in all body tissues except CNS and eye. Half-life is 1 to 4 hours. So adverse effects of interferons: acute flu-like syndrome, because it is infection, we produce it is given to the body, so there is a fever and headache. Bone marrow suppression is there, granulocytopenia, thrombocytopenia, neurotoxicity, confusion, seizures can also occur, and we have a cardiotoxicity and arrhythmia and impairment of the fertility. So these are the adverse effects of the interferons. Now, antiviral therapeutic use of interferons, where we use? We give in the chronic hepatitis B and C. Complete disappearance is seen in 30%. HZV infection in cancer patients, to prevent the dissemination of the infection, we can use antiviral drugs in these conditions. CMV, cytomegalovirus infection in renal transplant patients. Condylomata acuminata given by intralesional injection. So complete clearance is seen in 50% of the cases. Hairy cell leukemia in combination with zidovudine, AIDS-related Kaposi's sarcoma. So these are the, I would say, interventions where we can give the interferons, and these are the, I would say, 6, I would say, I enumerated over here. Now you have to remember this disease: influenza, amantadine, and rimantadine alternative. And pneumonia, bronchiolitis, we have ribavirin, and this is the drug of choice. We don't have alternative. Genital herpes, we have acyclovir, another is foscarnet. We have keratitis, conjunctivitis, which is trifluridine, and hydroxyuridine is the alternative. Then we have encephalitis, acyclovir is the drug of choice. We have neonatal HSV infection, it is acyclovir. Herpes infection, we have acyclovir, and foscarnet is the alternative. And VZV, we have in normal host in no therapy. Immunocompromised patient host are during pregnancy, acyclovir, foscarnet is the alternative. CMV, we have retinitis, ganciclovir is the drug of choice, and foscarnet is the number 1. HIV, we have AIDS, HIV antibody positive with CD4 count is less than 500 per millimeter cube. It is zidovudine plus minus protease inhibitors. So didenosine and staurovidine is there. HBV, HCV, we have hepatitis B and hepatitis C interferons of the drug of choice. So antiretroviral drugs, I will be taking another class, and I'm sure that in the next, I would say, Tuesday, it will be the antiretroviral drugs, and you should be ready about that. And today's lecture, so you should know the different classifications. You should know hepatitis C virus, hepatitis, what are the different drugs, and what is their mechanism of action, and what is kinetics and dynamics. That is very important, and you should know about that. You should know about the H1N1, and you should know about the, I would say, COVID-19, that what is the armamentarium, but there is no final drug, but there are some drug options, there are some targets that has been identified. Okay, thank you very much. Be ready for the, I would say, exam once you come to the college, or oral also, or viva voce also. Okay, thank you very much.